Hi everyone, and in this video I am going to discuss a topic NSAIDs. So the full form of NSAID is non-steroidal anti-inflammatory drugs. Now apart from NSAIDs, do we have any other anti-inflammatory drugs? Yes, they are steroids. But these are non-steroidal anti-inflammatory drugs, and the drugs are mainly used as analgesics. They are mainly used as analgesics. What is analgesia means pain, analgesic means they decrease the pain. Now, whenever we think of analgesics, there are three type of pain we see in the practice. The pain because of the musculoskeletal pain. So the pain arising from muscle or the skeletal, that is bone or joint. The pain because of cancer, or the pain which is visceral pains, or the pain which is from the nerve, they are called neuropathic pains. So the pains what the patient comes are musculoskeletal, cancer, visceral pain, and neuropathic pain. So where do you use these NSAIDs? NSAIDs are basically used to manage the musculoskeletal pains. So the musculoskeletal pains, we use NSAIDs. What about cancer and visceral pain? The drugs what we use are opioids. What about the drugs what we use for neuropathic pain? For neuropathic pain, we use certain drugs called pregabalin. Similar to that, one more drug called gabapentin. An anti-epileptic drug called carbamazepine. And an antidepressant, it is a tricycle antidepressant, that is amitriptyline. So these are the drugs what are used in different pain, but what we are concerned now is to manage musculoskeletal pain. So let us start our topic with that introduction, the NSAIDs, non-steroidal anti-inflammatory drugs. Now, what is their mechanism of action? How do they work? To understand that, you need to understand there are enzymes called COX. So the COX stands for cyclooxygenase, and the COX is going to give rise to prostaglandins. And prostaglandins are responsible for causing fever, and they are responsible for causing pain, and they are responsible for causing inflammation. So the enzyme COX, that is cyclooxygenase, will give rise to prostaglandins, and that prostaglandins are responsible for fever, pain, inflammation. So if you want to manage the pain, fever, inflammation, what should I do? I should suppress the prostaglandins. How do I do it? By inhibiting COX. So most of the NSAIDs, non-steroidal anti-inflammatory drugs, they work by inhibiting the enzyme cyclooxygenase. Now, talking about COX, there are two important types of COX, COX-1 as well as COX-2. These are the two major types of cyclooxygenase what we have. Now, COX-1 is important. It is responsible for managing the gastric epithelium. So it will produce the prostaglandins which protect the stomach from acid. Second, it is also required for the platelet function. It is responsible for platelet function. And also this COX-1 is responsible for the kidney function. So basically, if you see the COX-1 activity, the activity of COX-1 is good for us. What about COX-2? COX-2 produces the prostaglandins, and COX-1 also produces certain prostaglandins. But these prostaglandins will be helpful for gastric, platelet, and kidney. But COX-2 produces prostaglandins which are responsible, as I told earlier, fever, pain, and inflammation. So fever, pain, and inflammation, COX-2. So if I want to stop the fever, treat the pain, and stop the inflammation, what should I inhibit? Obviously, it looks like COX-2. But when we discovered NSAIDs, they block both COX-1 as well as they block COX-2. So they were not selective for one or two, they were blocking both. So what is the problem when you block the COX-1 also? The gastric epithelium is not protected, so patient will have gastritis and that will lead to peptic ulcer disease. So we call it as NSAID-induced peptic ulcer disease. Now, when the platelet function was interfered, so patient had a risk of bleeding. The patient had a risk of bleeding. And when the kidney functions are interfered, patient will have a problem called analgesic nephropathy. So the kidney function will deteriorate. The kidney functions will deteriorate. So if analgesics are used, that is particularly NSAIDs are used for a very long period, patient may have gastritis and peptic ulcer disease, patient may have risk of bleeding and the kidney failure. It takes longer time, but this is the risk. So NSAIDs, based on the inhibition of COX-1 or COX-2, they are classified in different groups. So let me tell you that. Number one, we have a drugs which inhibit both COX-1 and 2. They are called non-selective COX inhibitors. So they inhibit 1 and 2, they are called non-selective COX inhibitors. And number two, we have certain drug called preferential. They are called as preferential COX-2 inhibitors. And third, we came across a drug called selective COX-2 inhibitors. So these are the three basic classifications of NSAIDs. We'll go one by one. First, we'll take up the non-selective COX inhibitors. Number one, the non-selective COX inhibitors. The meaning is they inhibit both COX-1 and COX-2, both are inhibited. Now the enzyme, COX is an enzyme, so you can inhibit the enzyme in two ways. Either you can inhibit the enzyme irreversible, or you can inhibit reversibly. So there is only one drug which can inhibit irreversibly, and the drug which inhibits that is called aspirin. So aspirin is also called as acetyl salicylic acid. Then all others, rest all what I am going to discuss later, they are reversible. So the only irreversible COX inhibitor is aspirin, aspirin, aspirin. So I'll be discussing under this heading the reversible and irreversible COX inhibitor. So non-selective we have irreversible and reversible. So let me take up the irreversible COX inhibitor. The name is called aspirin. The name is aspirin. Now most of the concept about aspirin can be learned by the name itself. So let me write the name. So A stands for the drug has anti-platelet property. So the drug has anti-platelet property. So the A stands for antiplatelet. Now the antiplatelet property is seen with low dose of aspirin. So we call it as low dose aspirin. How much is low dose of aspirin? It ranges between 40 to 325 milligram. That is the low dose of aspirin. What happens when we use low dose of aspirin? What happens? They inhibit the enzyme COX irreversibly in platelets. So they inhibit the enzyme COX in the platelets. So when you inhibit the enzyme COX, there is decreased thromboxane A2. So thromboxane A2 synthesis is decreased because the enzyme inhibition is irreversible. Then when the thromboxane A2 decreases, there is decrease in platelet aggregation. Platelet aggregation. So this is the mechanism. Remember, they inhibit the enzyme COX irreversible in platelet. You may ask a question, sir, can the platelet produce fresh COX enzyme and synthesize thromboxane A2 later? Not possible because platelets lack nuclei. Platelets lack nuclei. So because they don't have nuclei, they cannot synthesize new enzyme. So once they inhibit the enzyme irreversibly, a fresh platelet should come back. So even when we use aspirin, the aspirin can work up to 7 days till the new platelet come to the action. So aspirin is an example of hit and run drug. The meaning is aspirin stays in the circulation for very few hours, but the action lasts for very long. The antiplatelet action lasts for very long period. The reason is it's an inhibitor of COX enzyme irreversible. So one more platelet has to come fresh to start aggregation. Now the question is, why we only have to use low dose? What happens when I use high dose? Now when I use high dose of aspirin, will the antiplatelet effect remain? Remember, this is the platelet and this is the blood vessel. So in the blood vessel, we have a synthesis of PGA2 and platelet is going to synthesize thromboxane A2. Now remember, the thromboxane A2 is responsible for aggregation and I2 is responsible for inhibition of platelet aggregation. Now when we give low dose of aspirin, it only acts on platelet and decreases thromboxane A2. It decreases thromboxane A2. But when I use the dose high dose more than what I have mentioned, higher dose, it not only decreases thromboxane A2 in platelet, it also decreases PGI2 in the blood vessels. So the net effect is, it will not have no effect on platelet aggregation since it has decreased both. So the antiplatelet effect is not seen. No antiplatelet effect. No antiplatelet effect is seen when you use higher dose. So both the thromboxane A2 as well as both the thromboxane A2 as well as PGA2 comes down with the higher dose. But in lower dose, only thromboxane A2 comes down and PGA2 still works and platelet get inhibited. So that's why low dose will have antiplatelet activity. Low dose will have antiplatelet activity. So number 1, A, antiplatelet activity. And remember, during MI, the dose of aspirin should be 160 to 325 milligram. That is the dose of aspirin during myocardial infarction. Now once we are done with A, one more letter, that is A itself, it has antipyretic action. So it can decrease the fever. And it is considered the drug of choice for rheumatic fever. Aspirin is the drug of choice for rheumatic fever. Next, it also has analgesic property and it can be used in the osteoarthritis. It can be used in rheumatoid arthritis, so arthritis condition. Another A, it has anti-inflammatory property. So it can produce anti-inflammatory property. So this is the reason it can also be used in osteoarthritis and rheumatoid arthritis. That is A. So A for, remember, antiplatelet, antipyretic, analgesic and anti-inflammatory property. Then the next letter in aspirin is going to be S. The S stands for the drug follows saturation kinetics. Drug follows saturation kinetics. What is the other name for saturation kinetics? It's also called as zero order or mixed order. So when you use the aspirin at normal dose, it follows first order. But when you increase the dose of aspirin, it follows zero order. So that is the meaning of the drug following saturation kinetics correlate with the general pharma. The drugs which follow saturation kinetic are VAT powered drugs. Second important problem is salicylate poisoning. So aspirin poisoning is very common. Many times the child will see the tablet kept in the home and it will swallow the tablet and come to the casualty with aspirin poisoning or salicylate poisoning. And remember, salicylate is what it is, a acetyl salicylic acid. So aspirin is acid. So whenever the patient comes with salicylate poisoning, you should maintain airway breathing circulation and do the gastric lavage. So since it's a acid and we don't have an antidote, so we need to do two things. We have to give sodium bicarbonate. Why do you give sodium bicarbonate? Since it's an acid, it can cause acidosis. So to treat the metabolic acidosis, we use sodium bicarbonate. Second one is, why do we give sodium bicarbonate? Is to alkalize urine. So we need to alkalize urine. Why should I alkalize the urine? The reason is acid drug in alkaline urine is ionized and it is easily thrown out. Along with that, you can also do hemodialysis to remove the salicylate out. So we are done with A, yes. So next, B. Now it has shown to prevent colon cancer as well as it has shown to prevent eclampsia if it is used as prophylactic. If it is used as prophylactic therapy, it has shown to decrease the incidence of colon cancer and preeclampsia. And also, since it's an antiplatelet drug, it can prolong the bleeding time. So BT stands for bleeding time. So we are done with A, S, P. Now I means it's an irreversible COX inhibitor. This is the only irreversible COX inhibitor what we are using in therapy. So one more I is it increases uric acid. It increases uric acid if you are using it less than 2 grams per day. And that is the reason this is contraindicated in gout patient. Aspirin is contraindicated in gout patient because gout already the uric acid is very high. We don't want to take a risk. Now we are done with A, S, P, I. So the next letter is R. So the drug can produce a syndrome called Ray's syndrome. Now which patient are prone for the syndrome and what we see in syndrome? We see in the syndrome the damage to the brain, that is encephalopathy, and damage to the liver, that is liver damage. So this is seen. Which patient do we see this? Now suppose we give aspirin to a child less than 12 years. So child less than 12 years and the child has viral fever. If you give aspirin, this is what happens. So don't give aspirin to a child with fever unless you have ruled out the viral fever. So viral fever, child less than 12 years, if you give aspirin, it has shown to produce Ray's syndrome. Then I stands for it causes ion tapping. So the drug undergoes ion tapping. What is ion tapping? I will explain that. Now this is the stomach and these are the cells in the stomach. Okay, so these are the cells in the stomach. Let me draw that. Okay, so you know that aspirin is acidic drug. So aspirin is acidic drug, and when we place it in acidic medium, so the pH of the stomach is acidic, so no problem. The drug is non-ionized and it will move into the cell. Now what happens when it moves into the cell? Inside the cell, the pH is around 6.27. So comparatively, the pH has risen up. So when you place an acidic drug in a basic environment, 6.8 to 7, so the drug will become ionized. So when it becomes ionized, it cannot go out of the cell. So the drug will be trapped inside. So that is called ion tapping or ion trapping. Now the reason why we are worried about ion trapping is the drug is stayed inside the gastric epithelium and that will lead to higher risk of gastritis. Now for further understanding, we have discussed a concept called pKa in general pharmacology. Please refer to that. You'll understand in a better manner. So pKa of aspirin is around 3.5 and if you keep it in acidic environment, no problem, but when you keep it in a pH like 6.8 to 7, it will be an alkaline environment for the drug. So the drug will be ionized inside the cell and it will be trapped inside. So this is the cell I have expanded to you. So we're done with aspirin. So A, S, P, I, R, I. The next one is N. So N for it can produce nephropathy. If you're using it for any NSAID, if you use it for a very long period, they can cause analgesic nephropathy. They can cause analgesic nephropathy and it can cause pathologically papillary necrosis. And another important aspect is aspirin is used to treat a condition called niacin-induced flushing. Aspirin is used to treat niacin-induced flushing. So this is the treatment. Now coming to the aspirin as such, I have explained the drug in the name itself. A for antiplatelet, analgesic, antipyretic, anti-inflammatory. S for salicylate poisoning, saturation kinetics. I for irreversible inhibitor, and it increases uric acid. R, Ray syndrome, don't give it in children less than 12 years with viral fever. Then I for ion tapping. Then N for the nephropathy, and it's used for niacin-induced flushing. And P, aspirin. P for it prevents the colon cancer and eclampsia and prolongs bleeding time. Nowadays, the major use of aspirin is in the prophylaxis of MI as well as stroke. This is the method. Moving on to the next important aspect, the B, they are called non-selective reversible COX inhibitor. So until now what we discussed, aspirin is non-selective irreversible COX inhibitor. The drug is called indomethacin. So first drug what we are going to discuss is indomethacin. So indomethacin, apart from inhibiting COX, it has additional anti-inflammatory property. It has additional anti-inflammatory property. And it can also decrease neutrophil chemotaxis. It can decrease neutrophil chemotaxis. So one of the good analgesic. So where to use it? It is used in OA for osteoarthritis. It is used in rheumatoid arthritis. It is used in gout. So indomethacin is used in osteoarthritis, rheumatoid arthritis as well as gout, and also it is used to close patent ductus arteriosus. Very, very important point. Indomethacin is used to close patent ductus arteriosus. So whenever you come across the patent ductus arteriosus, to close it, we have drugs. There are 3 drugs commonly used. Indomethacin. If that is not there in the option, we have ibuprofen. If that is not there, aspirin. These are the drugs available to close patent ductus arteriosus. Now moving on to the adverse effect of indomethacin. You know that all the drugs, Nsaids, they cause gastritis. But the most common adverse effect what we see with indomethacin is severe frontal headache. Severe frontal headache is the most common problem what we see. Now, the question asked in the exam is, can we use indomethacin to treat headache? Yes, you can use it. It can cause frontal headache, but you can use it to treat headache also. Please mark that point. Second, in some people it can cause psychosis, hallucinations, and it can increase suicidal tendencies. So that's why it is contraindicated in patients who are epileptic. It can trigger the seizures. Patients who are depressed or patients who are psychotic. So these are the problems what we see with indomethacin. Beautiful drug, but one of the common problems is severe frontal headache, psychosis, hallucination, suicide tendency. It has additional anti-inflammatory property, decreases neutrophil chemotaxis, all those things. Now, apart from indomethacin, the other drug what we have is ibuprofen. The name is ibuprofen. Ibuprofen is used as analgesic in children, a very beautiful analgesic in children. It is also used to close patent ductus arteriosus, and it has shown to produce a rare adverse effect. It has shown to produce a rare adverse effect that is called aseptic meningitis. It is known to produce aseptic meningitis. So similar to ibuprofen, we have ketoprofen. Then the third drug is mefenamic acid. The name is mefenamic acid. The advantage of mefenamic acid is it gets concentrated at uterus, and it decreases the prostaglandin activity in uterus. So that's the reason it is used for painful uterine spasm, that is dysmenorrhea. It is also used as antipyretic. So that is mefenamic acid, and most of you know that mefenamic acid is used in uterine condition, that is dysmenorrhea, and also it is an antipyretic drug. So basically, three important drugs you need to remember: indomethacin, ibuprofen, mefenamic acid. Very, very important. The fourth drug is paracetamol. Now, paracetamol is one of the special drug, and it has another name. It is also called by a name called acetaminophen. It is also called as acetaminophen. This paracetamol has a very good analgesic property. It's a very good analgesic and very good antipyretic drug. It can reduce the fever, but it's a poor anti-inflammatory drug. It's a poor anti-inflammatory drug. Yes, paracetamol. Now, mechanism of action is told that it's a non-selective COX inhibitor. But there are certain theories which propose that the drug has a inhibition of an enzyme called COX-3, particularly in hypothalamus. So hypothalamus is the one which controls the body temperature. So by acting on hypothalamus, it decreases fever. That is one of the importance of this. Then why it has poor anti-inflammatory effect? Because there is a theory proposed for that, is peroxide theory. Now what is peroxide theory tells us? Whenever there is inflammation, the regeneration of peroxide. So peroxide will not allow drug to inhibit COX. So if the COX is not inhibited, there is no anti-inflammatory property. So this is a different thing what we see with the paracetamol. The non-selective COX inhibitor, that's a major action, but why it is special? It has shown to inhibit a different type of COX-3, that is in hypothalamus. Why it will not work on inflammation? The peroxide theory. Continuing with paracetamol, what are the specialties of paracetamol? See, paracetamol is one of the analgesic and antipyretic which are used in certain people. So you can prefer it to use in children, in a child, because you took the example of aspirin where you see a Raynaud syndrome, that is not seen. You can also use it in an asthma patient, no problem. It will not cause bronchoconstriction. If you remember, aspirin can induce asthma. So there is something called aspirin-induced asthma, and that is not seen with this paracetamol. Not only that, certain Nsaids also can cause bronchoconstriction by inhibiting the COX pathway. So that is not seen with paracetamol. So it is one of the safest drugs, and it is one of the safest analgesic in a patient with chronic kidney disease or renal failure. So I am talking about PCT, paracetamol. The name itself is having para, that is good one. So paracetamol is a very good analgesic in a child, in an asthmatic patient. It's safest analgesic in CKD patient, and it is also the analgesic of choice. So analgesic of choice in a patient with osteoarthritis. Osteoarthritis is the analgesic of choice. So can we use it in pregnant women? Yes, it's safe in pregnant. It's safe in lactating mother. So these are the advantages of paracetamol as a drug. But only drawback is a poor anti-inflammatory property. Now, another important aspect is the metabolism of paracetamol. Let me explain that paracetamol metabolism. Very, very good topic for that. Now, when we use paracetamol is metabolized by particularly the glucuronide conjugation and sulfate conjugation and made inactive. So it is made inactive by this paracetamol. The 98% of paracetamol is undergoing this reaction. But there is one more pathway, that is by the enzyme cytochrome 2E1, it is converted into a compound called NABQI. So what is the full form of this? The full form is called N-acetyl para, B for benzo, Q for quinino, and I for imine. So that is NABQI. Now from NABQI we get an acid called mercapto uric acid, and that will go in urine. So mercapturic acid will go in urine. So paracetamol 1 to 2% is following this pathway. Majority 98% is inactivated by glucuronide pathway. So from NABQI to mercapturic acid, what we require is glutathione. So normally this is how the paracetamol is metabolized, no problem. We give normally, nothing happens. Suppose a patient has taken 10 tablets of paracetamol, that is paracetamol overdose. Let us assume 10 tablets of paracetamol he has taken and come to the hospital. Now when he takes 10 tablets of paracetamol, the problem is this pathway, what I am showing, glucuronide pathway, gets saturated. So the paracetamol gets diverted to the other pathway, that is through cytochrome 2E1, and you get NABQI. The problem with NABQI is it is hepatotoxic. But when we give normally, it will not cause toxicity because it is neutralized by glutathione. Glutathione will neutralize that. But in overdose, NABQI is high and glutathione stores gets depleted. Patient will have hepatotoxicity, and if you don't interfere early, there is a chance of liver failure. So any paracetamol overdose, the toxic compound is NABQI. And what is the antidote? The antidote for paracetamol toxicity, the antidote is called N-acetylcysteine. It is called as N-acetylcysteine. What does it do? When we give that, it replenishes the glutathione stores. It will replenish glutathione store, and the toxic metabolite is converted to mercapturic acid and it is thrown out of the urine. So please keep this in mind. What is the toxic metabolite and what is the antidote for paracetamol overdose? So that is about the beautiful drug paracetamol. And also paracetamol, can we use it in a patient with bleeding disorder? Yes, you can use it, but you cannot use other NSAIDs. That is a specialty. So until now we have discussed paracetamol. The other minor drugs you need to keep in your mind. Number 5, we have a drug called ketorolac. Now ketorolac can be given IV. So intravenously it is used for post-operative pain conditions. So post-operatively, if the patient complains of pain, we use ketorolac. And ketorolac is also available as eye drop for any pain arising in the eye. The other drug is nabometone. So nabometone is a prodrug, and it is usually given to treat a condition called osteoarthritis condition. The 7th drug is a drug by the name piroxicam. So piroxicam is considered one of the longest acting NSAID. Longest acting NSAID. What is the reason why it is longer acting? Pharmacokinetically, because it undergoes a circulation called enterohepatic recycling. So since it undergoes enterohepatic recycling, the drug is longer acting. Then we have a drug, it is called phenylbutazone. Phenylbutazone, and the drug has shown to produce bone marrow suppression. So the use is not so much common nowadays. So please keep these drugs in your mind, particularly for your exam point of view: aspirin, indomethacin, ibuprofen, then paracetamol and piroxicam. These are the major drugs in non-selective COX inhibitors you should keep in your mind. So once I am done with non-selective COX inhibitors, you know the problem with them except paracetamol, gastritis, the kidney damage and bleeding episodes. So the scientists wanted something else, and the second class of drugs what they came up with is preferential COX-2 inhibitors. So these are called as preferential COX-2 inhibitors. You read the name preferential, that means they block COX-2 preferentially more than COX-1. So they will inhibit both, but more COX-2 inhibition. So the advantage is less gastritis compared to other drugs. So what are the drugs in this category? The drugs are nimesulide. The nimesulide drug. Nimesulide is one of the beautiful analgesic antipyretic, but the problem, adverse effect of the drug is it is hepatotoxic. And it is banned. You cannot use it in less than 12-year-old children because of the risk of hepatotoxicity. Other countries have completely banned in every population, but in India it is banned in less than 12-year-old child. Then we have aceclofenac. Then we have meloxicam. Then a drug called etodolac and a drug called diclofenac. So you can remember by the mnemonic named, NAMED. So the drugs are named. So nimesulide, aceclofenac, meloxicam, etodolac and diclofenac. So these are preferential COX-2 inhibitor, but still the risk of gastritis is there, bleeding is there, but lesser compared to previous group. Then we came with one more category of drug, the third category of drugs, and they are called selective COX-2 inhibitors. So they inhibit only COX-2. So the chance of gastritis are very, very minimal or no. And all these drugs end with the name coxib. The drugs end with coxib. So what are used currently as are paracoxib. Remember P for parental, it is given IV, paracoxib. Then we have celecoxib, which is given oral, and a drug called etoricoxib. So these are COX-2 inhibitors. But certain COX-2 inhibitors are banned. For example, I will give an example of rofecoxib and a drug called valdecoxib. Now these two drugs are banned for usage, or instead of banned I can use a word withdrawn. The reason is they increase the risk of MI. Now why they increase the risk of MI? When we inhibited COX-2, in these patients there was decrease in prostaglandin I2. What is the role of PGI2? To prevent platelet aggregation, but when you decrease that, platelet aggregation increases. So that led to platelet aggregation. And the platelet aggregation will lead to clot formation and then MI. So these are banned. Now paracoxib is a prodrug, and after metabolism it will give rise to valdecoxib. But valdecoxib as a general drug, as a separate drug, is not used. It has been banned. So only 3 drugs are used: paracoxib, celecoxib, etoricoxib. And there was one more drug called lumeracoxib, and that is also banned because it increases L. Remember L for liver toxicity. So these are selective COX-2 inhibitors. So we were happy that we got COX-2 inhibitors, lesser chance of gastritis and all, but you see the risk of MI with this. So that is about the Nsaids. So if I tell you in brief, Nsaids, remember they are analgesics, antipyretic and anti-inflammatory drug. Basically, they decrease the activity of prostaglandins, which are responsible for fever, pain and inflammation. The housekeeping and the good one is COX-1. The pathological or the inflammatory one is COX-2. But when we use Nsaids in the beginning, we started blocking both, and there is a risk of gastritis, bleeding and analgesic nephropathy. So we have 3 classes of drugs: non-selective COX inhibitor, irreversible, only one drug aspirin, reversible, other drugs will come. Then preferential COX-2 inhibitors, the named drugs, and then selective COX-2 inhibitors, the risk of MI, and the banned drugs are rofecoxib, valdecoxib and lumeracoxib. So that is about the non-steroidal anti-inflammatory drugs. Thank you all.